Good morning.
Good
I'm
morning.
Lily. Happy Halloween. Um, I'm dressed as our wonderful program director, Carrie Payne. Um, um, and welcome to your annual pregnancy talk by a female fellow. I I'm going to be specifically focusing on pre-pregnancy counseling for people living with CKD. I initially was planning on just doing like a more broader women's health, kidney health talk, and realized that that's not possible in 20 minutes. So I pared it down to these topics. I don't have any disclosures. So for today, we'll identify predictors of maternal and fetal risk in pregnancy in people with CKD. We will discuss key components of preconception counseling for patients with CKD, and we'll talk a little bit about pregnancy-compatible medication strategies with patients with CKD, but I won't belabor on that point for too long. So my interest in this really came up from just getting to work with more variety of women as a consultant. I think I kind of lost that in internal medicine, and as we specialties, I got to work more with women of all kind of age groups and diversity. And this is not really a specific patient, but really kind of combination of the cases that I have seen so far. So we'll discuss this woman who's a 35-year-old who had a kidney transplant in 2005 for FSGS. She's always had excellent graft function. Her creatinine is about 1.1, and she does not have proteinuria currently. Her blood pressure is excellent at 110s over 60s. Her meds are pretty minimal: losartan, tacro, MMF pred, and atorvastatin. And then she identifies as queer and she's single, but she is thinking about starting a family. And she originally asked me, she's thinking about adoption, and if I could sign some of the paperwork for her. And we started talking about, well, is adoption that you want, or do you think, or do you want to try to get pregnant too? And she didn't realize that getting pregnant was an option for her. So this is how the conversation came up. So you might ask, why should we care? This seems like an OB domain. Maybe they should see MFM. But I'll make a point that, it's not a very small number. About 3% of pregnant people have CKD, and 1 in 750 pregnant people have advanced CKD through 3 to 5. CKD, we know that CKD affects pregnancy outcome, but let me make a point more importantly for us that pregnancy also affects kidney outcome and how we're going to manage their kidney disease after the pregnancy. And many reproductive risks that kidney disease pose are modifiable, and that OB-GYN might not feel the most comfortable managing. So we can, I think it is appropriate for us to be involved in these conversations for pre-pregnancy counseling. So for our patient, it's going to be a kind of complex discussion that involves herself, her kidney health, and the baby. And these are obviously all interconnected. And some of the common questions, this is from the International Society of Nephrology Preconception Counseling in Women with CKD guideline, that these are the common questions that nephrologists should think about addressing when we're doing preconception counseling. So the number one problem is, can I have a baby? Like, is it physically possible? Which was the question that our patient had. Should I have a baby? Which is more risk-benefit discussion. When is the best time to have a baby? What is the risk to my kidneys? What is the risk to my baby? And what care will I need in pregnancy? And we will explore these questions. So first, we'll talk about, can I have a baby? Is it physically possible? So the decrease in fertility from CKD really is it's by from hypogonadism, and kind of broadly speaking, the uremia and the metabolic derangements that happen with CKD, with this, especially with advanced CKD, really affects the GnRH here. So it decreases the GnRH release, which affects the rest of the hormonal axis, and then leads to downregulation of hormone release from the gonads, and in both male and female. And worth to mention that if somebody has been exposed to cyclophosphamide, that will affect fertility. This is why we counsel patients before we give people cyclophosphamide. But this is kind of like the beginning of how a CKD starts to affect fertility. So if we talk specifically about female fertility, and excuse my language, I'm going to say female fertility, and by that I mean ovaries and uterus. People who have ovaries and uterus doesn't pertain to the gender identity. Anti-Mullerian hormone, you may be familiar, is a very widely used surrogate marker for ovarian reserve. It's not really associated, like directly associated with infertility or fertility difficulties, but it is just a widely used marker. It is not directly related to fertility. But if you look at the graph here, as you can see, people with CKD, whether it be stage 1 or 2, they do have lower level of AMH for what it's worth. But we all know that a lot of ESRD patients or CKD5 patients, they stop having menses, which mean that they have stopped ovulating, which obviously will make pregnancy difficult. CKD also seems to affect male fertility as well. We talked about how it leads to hypogonadism. There has been studies that have demonstrated that this leads to low testosterone level in men. It causes low libido, although there are ways to harvest semen without ejaculation. So if you go through fertility treatment, that might not be an issue. CKD also seem to be associated with semen quality, although I will mention that these qualities haven't been shown to affect fertility in outside of like IVF domain. So if somebody's going through unassisted or like try to like conceive naturally, it actually hasn't been shown that these qualities affect fertility. So it does seem to affect male fertility. I don't know if it's as much as female fertility, but it's just worth mentioning that it's not just women that get affected by this. So what can we do as kidney doctors as for fertility treatments? It's actually not just OB-GYN that can do something for our patients. So if somebody's near dialysis or is on dialysis, intensive dialysis even before pregnancy seems to be helpful in decreasing BUN. We also target for BUN less than 20 for these women. Although dialysis seemed to not help male fertility, kidney transplant seemed to help with fertility for both male and female. So that is interesting. And then, of course, assisted reproductive therapy, and by that I'm talking about IVF, IUI, ICI, the whole shebang. That is also possible. Although higher rates of complications exist for patients with CKD, predominantly preeclampsia, actually. And I just wanted to show you this graph. I thought that it was interesting. One study looking at kind of fertility change, and the red line here is red line here is patients who are not getting dialysis, but with CKD, who are not requiring dialysis. Blue line here is dialysis cohort, so people who started to get dialysis. And then the yellow line here is people who got transplant and not dialysis. And you can see fertility increases, like it gets better with dialysis and a transplant. With transplant, it gets better more. That's a weird way to say it, but there's a more improvement, but not quite back to baseline. So we can see that intensive dialysis does improve fertility. Transplant improves it more, but not as much, not like quite back to baseline. So to summarize to the question of can I physically have a baby, the answer should be fertility may be reduced with CKD. Conception is difficult with especially ESRD. Transplant will be helpful to a point if somebody's nearing transplant, and fertility treatment is an option. And some of this we can take care of, and a lot of it should be done with OB-GYN. So the next question we will explore is what is the risk to my kidneys and the patient's health. So renal function does decline it seems like in a step down fashion during pregnancy, and this is a study that came out of the UK in 2020. Let me just orient you here. So this is graphing EGFR drop. On the leftmost side is pre-pregnancy, and then they didn't measure it during pregnancy because creatinine is unreliable, and then Postpartum, they also measured EGFR with serum creatinine. And then this is people with CKD3A, CKD3B, CKD3 to 5. And what's interesting is the rate that the EGFR declines was just by, because they have kidney disease. The slope of the graph, if I can convince you, before and after pregnancy is about the same in all three groups. But if you drew a line between pre-pregnancy and post-pregnancy, the slope of that line, it does seem to be sharper or it seems to be higher than the rate that the EGFR was falling before and after. So there seems to be this step down decline of kidney function during pregnancy. So it's not just the disease course that's taking the kidney function down, as something about the pregnancy is also decreasing the kidney function. So here is another way to kind of demonstrate it. I thought this graph was interesting, this table was interesting. So you can kind of calculate how many years of kidney function you're losing based on where you're starting. So based on this study, if you start at 3A, during pregnancy, you actually lose 1.7 years of kidney function. So it's not actually 9 months of kidney function. If you start at 3B, you lose 2.1 years of kidney function. And if you're 4 to 5, you lose 5 years of kidney function. So something to think about as somebody who has CKD stage 4 to 5. They are pregnant, and if you thought that they would be on dialysis within 5 years from that point, then it might be worth prepping the patient for dialysis, even before the 5 years is up, because the kidney function might tank at that time. Interesting that the transplant patients who don't have quite normal graft function and has CKD 3 to 5 also seem to lose about 4 years of kidney function during pregnancy. So then how do we know who might have like more of this step down decline in kidney function? So where you start in CKD seem to matter. And you might have seen in the graph that actually CKD 4 to 5 group has steeper downgrade. But I will show you, if you look at this portion of the table, this is the same study from the other graph. The proportion of people who have 25% fall in their EGFR or on dialysis 1 year postpartum, the CKD3 group, 3A and 3B, 33% of those people had that. CKD 4 to 5, 90% of people had that. So where you start with kidney function really matters, and how much the kidney function will be affected by pregnancy. And another risk factor are chronic hypertension and UPCR. This is a UK study, which is why the unit's like that, but it's basically about 1 gram per gram. Seem to have low p-value and show that these are the predictors of the step decline in EGFR related to pregnancy from the study. So to summarize this question of what is the risk to my kidneys for pregnancy, the answer can be advanced CKDs associated with worse renal function after pregnancy, chronic hypertension associated with renal function, more proteinuria, more than 1 gram per gram associated with worse renal function. And this is, you can say we should optimize your blood pressure and proteinuria, or even consider transplant if you're close to it before you get pregnant. The next question we'll talk about is what is the risk to my baby? And I think we know that CKD increases some fetal complication, and I just wanted to show you some data that this is a CJASN article that came out of Ontario, Canada. And as you can see, the risk for preterm delivery goes up as EGFR falls. And birth weight lower than 2.5 kilos also go up as the EGFR falls. Some other things that I want to share with you, CKD severity, hypertension, and proteinuria all seem to be associated with higher risk of preterm delivery and low birth weight. And higher rate of stillbirth and severe CKD as in CKD 4 to 5. But other than that, like in CKD 3, actually that signal wasn't there, and stillbirth is very, very rare to begin with. And in CKD 3, it also seems to be very rare. And there's actually no increased risk of congenital malformation unless the person who gave birth had familial urinary tract malformation, which makes sense because that's a genetic disease. And diabetic kidney disease also seems to be related to increased risk of congenital malformation. But if somebody has CKD, like solely from lupus, for example, it might not have increased risk of congenital malformation. And this is interesting because like people might ask like what will the life for my child look like after immediately after birth. And there is some evidence that there might be increased risk for new divergence and developmental delay, but there obviously are a lot of confounding factors, and this actually hasn't been reproducible, and there are no longitudinal studies that, or like there aren't any like long-term studies that looked at how these babies develop into children and adults. So we actually don't have data to say one way or the other. Transplant patients still have risk of preterm birth and low birth weight, but it just seems to be less. So I will show you this table here that this is dialysis patients and this is kidney transplant patients. Dialysis patients, they gave birth around 30 weeks. Kidney transplant patients got to keep them in the oven for a little longer at 36 weeks. And preterm birth for dialysis patients, 90% of the dialysis patients had preterm birth. Transplant patients, about 50%. So that's a significant decrease. And then the percentile, the weight percentile as well, 33% of the dialysis patients had less than 10, was at less than 10 percentile, and then about 16% with transplant. So the risk is still there. It's higher than a non-CKD population, but it is definitely decreased than dialysis. So to summarize the question of what is a risk to my baby, the risk of preterm delivery and NICU admission, low birth weight is all there. Severity, hypertension, and proteinuria associated with higher risk. You can lower this risk with kidney transplant, and there's actually not a lot of data on how they develop as children and beyond. So when is the best time to do this then with people with CKD? It really depends on your kidney disease. The expert opinion is that you should at least 6 months of disease remission and things like autoimmune disease. If you're a transplant patient, should wait at least 12 months after transplant. Obviously should be off mycophenolate for at least 6 months. And if somebody's young and has advanced CKD, it might be risk might be better mitigated by doing the transplant first and then trying for pregnancy. So I won't belabor this point too much because we know this, but these are the medications that should be thought about discontinued before pregnancy. So immunosuppression meds, mycophenolate, cyclophosphamide, lipid-lowering therapy is also thought to be teratogenic. Diabetes medications, metformin should be stopped. SGLT2 and GLP-1 receptor agonists it hasn't been studied in pregnant populations, so we just stop it because we don't know. And antihypertensives, MRA should be stopped. ACE inhibitor and ARBs I'll tell you a little bit more about because I found this topic really interesting. So I was taught, and I think a lot of us was taught, that it is teratogenic and it needs to be stopped before people try for pregnancy. And in reproductive age women, we need to counsel them on contraception. It actually seems like, so this kind of came out of this study that was done in 2006, that first trimester exposure to ACE inhibitors and ARBs might lead to congenital malformation. But it turns out that they didn't really control very well for existence of hypertension and diabetes. And as we saw before, diabetic kidney disease is a risk factor for congenital malformation. So in the subsequent studies that have looked at, like this study, for example, have looked at more than 30,000 pregnant people, and they did when they do control for hypertension and diabetes, that signal goes away. It definitely is associated with worse outcome in the second and third trimester, and it's fetotoxic, so you should not use that in second and third trimester. But actually, it's kind of controversial whether ACE inhibitor ARB in the first trimester is actually harmful. And we saw that the controlling CKD as much as possible before pregnancy improves the kidney outcome. So it is just something to think about if an ACE and ARB is an important medication for a patient. So the last question of should I have a baby, that is a very complex discussion that involves the patient, the future child, the family, the medical team, the person who donated the kidney to the patient if it's a transplant patient. And it should be multidisciplinary discussion. It should be a long discussion, and it needs to be thoughtful. And as our patients advocates, I think we should definitely be a part of this discussion. And what care will I need in pregnancy? I learned that many places like Mass Gen, Ohio State, UNC all have women's health kidney clinic that specifically take care of this patient population. And at one point, I would love to be able to say, you can get that care, use that medicine. It would be really cool to continue to work with this diverse population of women and people who are trying to get pregnant. These are my references. Thank you so much for your attention. This is my mom pregnant with me 7 months. You can't really tell, but I am right in there. Thank you.
All right, very nice presentation. Thank you, Lily. We have a few minutes for any questions or comments. And I see Nisha has her hand raised. Yeah, Nisha, you want to start us off?
Sure. Really great talk, Lily. Super interesting. Um, I'm curious about this link between CKD and infertility. If we have a good order, what is our understanding of the non-hormonal mechanisms that may contribute to that link? I found it really interesting that more dialysis, for example, could increase fertility based on that figure that you showed. You know, why is that?
Yeah, thank you for that question. So, but I think my understanding is the uremic toxins and metabolic derangements, and I think that specifically like acidosis that may contribute to the disturbance of the hormone axes. So that's why it's not just dialysis, but intensive dialysis that lowers BUN to lower than 20 that seems to have benefit in fertility. So I think that optimization is what's really being helpful. And the question of then, well, can you say that CKD3 might not pose much of a risk? Which I think is an interesting question. I think it's really when you get to like severe CKD 4 to 5 that fertility seems to be meaningfully affected.
Got it. Thank you.
Sarah, did you have a question?
I did have a
Okay.
question. I was clapping and then raising my hand, and there was a lot of the hand motions. Lily, that was excellent. Thank you for all this evidence behind everything you were talking about. The one piece of evidence I'm curious about is when you mentioned the intensive dialysis to keep the BUN less than 20, just because it's a huge ask for patients. And if it were me, I would want to make sure that I had to do something like that if I was going to commit so many hours. So I was just wondering what the evidence base is for that recommendation.
Yeah, so as we saw, I think the evidence just saw that the fertility just went up a little bit with dialysis as opposed to no dialysis. But at the same time, I agree that it's a huge ask, which is why I think maybe just exploring transplant first is better. It's, getting pregnant on dialysis, the not just getting pregnant part is harder, but the pregnancy itself is harder. You have to continue intensive dialysis. Your fetal outcome might be worse. Like everything is just worse with dialysis. So if it's a transplant eligible patient, it might just be better to get them transplanted first before for best risk mitigation.
So did the numbers basically try to just mimic someone who wasn't receiving dialysis? Is that why the BUN of 20 was chosen?
Oh, I see. I see your question. That's a good question, and I actually don't know the answer to that. Why that number was chosen? Yeah.
Okay.
Chris, you have your hand raised.
Yeah, thanks. Lily, I really enjoyed this talk. And one question that came to my mind as you were talking about the CKD population separate from the transplant population is whether there's any testing or use of drugs to expedite metabolism when a pregnancy is found later than expected in order to try to remove or facilitate lower doses of whatever teratogenic drugs may be there. For instance, cholestyramine has been used, and I've used it a couple times in my transplant patients. What about in those with CKD or more advanced disease?
Sorry, Chris, is your question like what to do when pregnancy was found later after?
Yeah, it's both a clinical and a research question, I guess. Are you familiar with any meds and whether there's beneficial effect of cholestyramine for patients if you need to expedite metabolism of a drug during pregnancy?
I see. I don't think I'm aware of any, there are obviously meds that we need to dose differently after pregnancy. But yeah, cholestyramine, I'm not familiar with.
Yeah, I'm sorry if I'm not phrasing this in a way that's helpful. What I'm looking for is a way to help women who might find that they're pregnant when they're on medication that are potentially teratogenic. And the only one that I'm aware of is cholestyramine. And I'm just curious if you have experience or evidence of how well that works. If not, I'll look into it further and we can learn more. This is really helpful.
Yeah, it sounds great. Yeah, sorry, I don't think I have an answer to that, but thank you.
Thank you.
Sorry, Josh has a question here.
Awesome talk. I appreciate it. And so looking at like a dialysis population, is there any evidence for like different dialysis modalities like PD versus home hemo versus in-center or like favorable outcomes? Or is it just not a population that's been studied that granular?
I don't think it's been studied that granular. There was a study that I looked at that that had PD patients in it, and they weren't separated out from HC patient. That the study that I was showing, like dialysis versus transplant for fetal outcome. So I can't really comment on fertility, but they were grouped together and they weren't separated out. So yeah.
I'm reminded of, we had a patient at UW who was who unfortunately had like a fetal loss. And she was on home hemo and was transitioned to in-center hemo, and it's just like a lot of very different like treatments and
I see. Thanks.
All right. Lily, I had one other question before we move on for time, but I really thought the last study you showed about the ACE and ARBs in pregnancy and possibly, not having the same concerns in the first trimester compared to the second and third trimester. I'm curious, I think like many others, I've also been taught that those medications are quite bad in pregnancy. And, I certainly am concerned with the risk. I'm curious, would that change your management? And would you be one that would be a proponent of continuing those medications longer, knowing that a patient is pregnant?
Yeah, I think that's a great question. And I think the issue is that actually for the most of first trimester, people don't know they're pregnant because it's about at week 3 or 4, people find out that they're pregnant, which is, a good portion of their first trimester. And then if we tell patients that, oh, if you're trying to get pregnant, stop this really important medication, who knows how long it'll take that person to get pregnant. And then they're off this antiproteinuric, this awesome medication for their diabetic kidney disease. Their kidney disease might worsen during that time when we really don't know like what's the benefit of stopping it so early. So there are some, especially European providers, that will tell patients just continue it. Like if you're trying to get pregnant, just take a pregnancy test every 4 weeks, like when you know that it could be positive, and just stop as soon as it's positive. That way we're not like losing that effect up until pregnancy.
Oh, thank you. All right. Well, if no other burning comments or questions, I think we can move forward with our next talk. Thank you so much, Lee. That was really, really wonderful.